Ladies and gentlemen, to start our conference, we now have a short message from His Royal Highness, the Prince of Wales.
Ladies and gentlemen, it is a great pleasure to be able to pay a special tribute to the men and women who manage and deliver exemplary care for patients up and down the United Kingdom every single day. Much has changed since the NHS was founded 70 years ago, as it turns out, in exactly the same year that I was born. But the dedication and commitment of NHS staff has remained a constant feature throughout. Now, I have long held an interest in the delivery of healthcare from the perspective of treating the whole person rather than just a collection of symptoms. And as Plato observed, the cure of the part should not be attempted without the treatment of the whole. It is now more apparent than ever that such an approach is essential if we are to meet the needs of our aging population and support the growing number of people who are living with a range of long-term conditions. Furthermore, as you all know far better than me, poor health is not something which exists in isolation. Our communities, our lifestyles, the food we eat, the exercise we take, the water we drink, the air we breathe, the quality of our housing and sanitation all play a role, as do the fulfillment of the basic human need for purpose in life, meaningful work as a person and not as part machine, a sense of belonging, dignity, kindness, and self-respect. In practical terms, this means the NHS working with other services, as it does increasingly in the field of social prescription, and supporting people to care for themselves by helping them access the non-clinical services they might need to maintain a healthy lifestyle or improve their mental well-being. Introducing a more integrated approach to healthcare into the community is a pressing challenge for many of you, I know, and integrating healthcare while maintaining the high standards expected of the NHS will require a supreme effort from very special people. Luckily for us, we have more than 1 million of them in the United Kingdom who are up to the task. Healthcare, at the end of the day, is predominantly a person-centered process. We all see the extraordinary dedication and compassion of NH staff at times of tragedy, such as when terrorists struck in Manchester and London last year. However, patients and their families see it every day, as I remember so well when at the age of 13 being rushed in an ambulance on a 4-hour-long journey up the old A4, and in those days there was no M4, from my school near Newbury to Great Ormond Street with an appendix that threatened to burst. I shall never forget the care I received from all the wonderful doctors and nurses. In fact, when the time came to be sent home, I didn't want to leave at all. The NHS really does run on kindness and compassion, and never before has it been so vital. I know, ladies and gentlemen, you face particularly difficult challenges in the years ahead, and that you will discuss many of them this week. But I nevertheless hope you can take great pride in the fact that you deliver a truly caring service, and that during this NHS Confederation annual conference, you can learn from one another, celebrate the past, and plan for the years ahead. I can only offer you my heartfelt thanks for everything that you and your teams are doing in these challenging times. Your devotion to duty and to your patients is an immense tribute to what the NHS means, and I'm sure you will all join me in wishing the NHS a very happy birthday.
Ladies and gentlemen, please welcome to the stage the Chief Executive of NHS Confederation, Niall Dickson.
Well, good morning and a warm welcome to Confed18. It's great to see so many friends and colleagues here today to take stock after what's been a hugely challenging year, and for us to share problems and learn from one another, and as our strapline says, to celebrate the past and shape the future. And on celebration, I just want to pay tribute to the organisers of last night's tribute to the Windrush generation and their successors. It is 70 years since that ship docked at Tilbury, and that was just 2 weeks before the NHS was launched. The one has helped to secure the future of the other. And as we celebrate the birthday, we also celebrate 70 years of commitment from our amazing and diverse workforce. We're also very grateful for the Prince of Wales for his message. I do think it's significant that he not only wanted to wish the NHS a happy birthday, but to acknowledge the pressures which the system is facing, to thank you and your teams for all you're doing, and to throw his weight behind the efforts to make the service fit for the 21st century. Now, over the next couple of days, we'll cover a range of topics, from the opportunities for digital innovation, service transformation and integration, the routes to increasing efficiency and productivity, to the challenges of workforce and leadership. But whatever sessions you go to or whoever you bump into, we hope you'll leave with perspectives and practical ideas that you can take back into your organisation or your local health economy. This year we have a sort of rival to this plenary stage, which is mainly aimed at colleagues concerned with digital, estates, local enterprise and transformation. But please do feel free to be disloyal to this stage and switch your allegiance. Today the Focus On stage, as it's called, is about digital transformation, and tomorrow it will be about estates and how to tap into the local growth agenda. In the exhibition area, we have an in-conversation zone with Victoria MacDonald from Channel 4, who'll be chatting to various leaders across the health and care system. And there's also an innovation zone, which I recommend, which has got ideas from members, which you're more than welcome to plagiarise. I want to say a big thanks to all our sponsors and our exhibitors, and especially to our event partners, Allocate and Pfizer. I hope you'll also find time to explore the exhibition as a whole, and again, lots of ideas to improve care and save money. Now, we also want this to be, as far as possible, an interactive experience, and from time to time to test your views. To take part in the voting, you need to download the conference app. Now, if you've not already done so, then can you please follow these instructions now? The first thing is to search for NHS Confederation events in the App Store or Play Store. I think those are probably the easiest ways of doing it. Then open up on the app and tap Confed18. Is that coming along? Nods. Select Join, and then you need to create your account with an email and password. So I'll just give you a second or two to do that. This will enable you to take part in the votes that we've got during the conference. I hope the Wi-Fi is working sufficiently for you to be able to do that. Okay, just give me a rough idea. How many people have managed to download the app? Ah, wow, miles ahead of me. Okay, right, good. Okay, let's go on how to vote. So you've loaded the app. You're probably miles ahead of me already, but join the Confed18 event. Then there are 3 horizontal lines on the top left of the screen. That brings up the menu. On that, tap Programme, and then you find the relevant session on the programme. I think we're in the welcome session at the moment. And then we have the test question. And for this, the test question is, and I'm hoping this is going to appear as a slide here. Okay, so what issue should we prioritise when I'm going to interview Jeremy Hunt tomorrow? Should we look at transformation or workforce or ALBs or social care or funding, or should I prioritise the likelihood and ask him of him one day being Prime Minister? So those are the options, and if you choose, if you could vote on that now. Okay, votes are still going up, gives the vote number there. It's a bit unfortunate, actually, you can see the votes, because that might, in theory, influence how people choose to vote. Oh, I'll give them a boost. There are no LLBs there, you know. Okay. Okay, I'll give it a couple of minutes, a couple of seconds more, because there are certainly more than 136 of you here, as it were. However, it's interesting. When I was at the BBC, I used to interview people on the street, and if you compared it with what was actually going on in national polling, once you'd interviewed 15 people, actually you usually got about the right result. It's a really interesting statistical thought there. So I'm sure 163 of you is probably enough. Let's stop the voting now. Okay, could we have the result up, if that's possible, from the vote? That seems to have disappeared. Thank you. Right, that's people are still trying to get the votes in. Anyway, so transformation comes out at around 20%. Workforce, really interesting. Funding, it's workforce and funding. I mean, I think we probably could have guessed that anyway. And 6.4%, or is it 5.4% of you want me to ask him what his ambitions are for taking over number 10. I might use that as the excuse to ask the question anyway and say, it wasn't me, they just told me to ask this question in the first place. Okay, enough from me just now. I hope you have a really good conference. Please do come and see us on the Confed stand. But now, to reflect on the state we're in and where we're heading, please welcome former Health Secretary and former Chair of the Health Select Committee, now Chair of the NHS Confederation, the Right Honourable Stephen Dorrell.
Neil, ladies and gentlemen, thank you. We all know, do we not, that there are not many heroes in politics. Doesn't mean there's a shortage of aspirants. They try on the cloak, they flaunt themselves, they dazzle for a moment, and then, like Icarus, they fly too close to the sun and they're gone. But out of the humdrum crowd of politics, there occasionally steps someone who makes a real difference. As someone who served 36 years as a Conservative Member of Parliament, I'd hesitate to describe Anita Bevan as a hero. But I have no hesitation at all in celebrating his achievement in establishing the world's first universal healthcare system. Against the background of the developing avalanche of words that will mark the 70th anniversary of the NHS, I think we should pause for a moment to recognise just what it meant in the context in which it happened. After nearly 6 years of war and facing profound economic and political challenges, both at home and abroad, it represented a commitment that post-war Britain would find the resources to invest in a completely new and untested approach to health policy. Bevan was certainly committed to free access to care, but his vision went well beyond that. He understood that the purpose of universal healthcare is to secure what in this generation we call healthy outcomes for citizens. He put it this way in his own words in his book In Place of Fear. Preventable pain is a blot on any society. Much sickness and often permanent disability arise from failure to take early action, and this in its turn is due to high costs and fear of the effects of heavy bills on the family. Society becomes more wholesome, more serene, and spiritually healthier if it knows that its citizens have at their back the knowledge that not only they themselves, but all their fellows have access to the best that medical skill can provide. Bevan described those ideas as socialism in action. But I think that understates the extent to which he won support for the principle of universal health care that extends well beyond those who would describe themselves as socialists. Take but one example. The Economist magazine has occupied the epicenter of British liberal thought since 1843. But in April this year, it argued in its main editorial that universal healthcare is, in its own words, sensible, affordable, and practical, and that there is, once again in its own words, a principled liberal case for universal healthcare. The front cover of the same magazine proclaimed the objective, quotes, "Within reach, universal healthcare worldwide." So when we celebrate 70 years of the NHS, we celebrate the achievement of a man who promoted an idea which has developed its own life, independent of its political roots. It's won endorsement across the political spectrum and across a wide range of social, cultural divisions, both at home and abroad. When Danny Boyle celebrated the NHS in the opening ceremony of the London Olympics, he was celebrating a unique British achievement, but he was doing more than that. He was celebrating an idea which has the same universal appeal as the Olympic ideal itself. That, I think, is the true measure of Bevan's achievement. But for us, it's not enough simply to celebrate an idea. We can and we should acknowledge the vision of those who went before us and recognize our debt to their achievements. But then we have to move on from celebration to challenge. We can't just make the speech. We have to commit to making the hard choices which make the difference between aspiration and reality. That's why earlier this year, the NHS Confederation joined with the Health Foundation and the Institute for Fiscal Studies to sponsor the report on funding of health and social care between now and the 2030s. Every person in this hall is familiar with the resource pressures facing the NHS and social care. It could hardly be otherwise. Those pressures shape the daily experience of those who work in the sector. What's more difficult is to stand back from day-to-day reality and understand long-term trends. That was the question to which this report was addressed. It's been recognized as the most authoritative analysis since the Wanless reports of 2002 and 2006. But it's different from Wanless in one important respect. Wanless published two reports 4 years apart, one looking at healthcare, the other looking at social care. This report acknowledges what we all know, that it makes no sense to look at trends in the NHS separately from trends in social care. Both sectors serve the same communities, and failure in either leads to pressures in the other. More importantly, failure of the NHS and social care to work with each other and the rest of public services doesn't just lead to distorted demand patterns, it leads to worse outcomes and damaged lives. It violates the principles of universal health care, of which we claim to be the guardians. So this report looks at trends in health and social care together, and it draws two very stark conclusions. First, looking backwards, if allowance is made for the effect of the growing elderly population, it concludes that real per capita spending on health and social care services has not risen since 2010. Not the conclusion of a lobby group or of a party politician, but the evidence gathered by two of our leading commentators on public services and public finance. Small wonder our services feel themselves to be under pressure. But that provides the background to the second and even more important conclusion I want to highlight from the report. If we're to deliver the universal healthcare ambition ideal that we're so good at talking about, the authors of this report conclude that there needs to be a commitment to increase taxpayer resources available to both health and social care services at the rate of 4% per annum. Not 4% for the NHS at a squeeze on local government, or a special fund to ease the pressures on social care, but 4% per annum for the NHS and 4% per annum for social care, year on year, between now and 2030. Hard facts, hard choices. As we celebrate 70 years of the NHS, we should remember they made a choice in 1948. They chose to be the first country in the world to commit to the principle of universal health care, and they did so without the evidence which has persuaded The Economist that at least on this subject, Bevan was right. We now have that evidence. The question for ministers is whether they act on it. So much for money. We shall return to that subject with the authors of the report in the next session. Before we do so, we want to recognize that it's not just money. When we speak of the challenges, it's always easier to focus on the challenges which face others, particularly politicians, rather than address the challenges we face ourselves. One of the biggest of those challenges that faces every generation of NHS management is the need to ensure that our services are flexible and respond quickly to the changing needs of the communities we serve. We're all familiar with the problem. Communities, in both senses of the word, communities inside the NHS and communities outside the NHS, grow used to established ways of working. We make the mistake of thinking that the familiar institutions are the essence of the NHS. We attach our loyalty to the institutions rather than to the values they're intended to deliver. Good management cherishes those values, but ensures that the structures change to allow the values to be better delivered. That's what lies behind the development of new structures for accountable and integrated care. Heaven knows we've talked about it for long enough. We all know that the individual patient too often experiences our services as a series of disconnected episodes rather than as a single joined-up service. That may have been unavoidable in the days of black and white television and fax machines, but there really isn't any excuse for it in the era of digital exchange and artificial intelligence. We sometimes think our task is to introduce new technology to support service delivery. That's not right. It's much more fundamental than that. Our task is constantly to reinvent our services to use the full range of resources that are available to us to meet the needs of our citizens. Requires new methods of working within the NHS, and it requires new relationships with other partners in delivering joined-up public services to meet the needs of local communities. The practice of universal healthcare is not a monopoly interest of the NHS. Michael Marmot rightly reminds us of the importance of the social determinants of health, and we meet in Manchester, which has been pioneering new relationships across the NHS and with elected local government. Within the NHS Confederation, we aim to support that process within and beyond the NHS, and particularly with the Local Government Association. Integrated and accountable care is not just a matter of improving the experience of care of the individual citizen, though that should be reason enough to rethink our services. Failure to implement new working methods across institutional boundaries undermines the effectiveness of our service. It undermines our commitment to the very principles of universal healthcare. The foundation of the NHS was a commitment to an untested idea. The best way to celebrate its 70th anniversary is to commit once again to be in the vanguard of testing new versions of best practice. Which brings me finally to the people who deliver that best practice. One group in particular Niall's already mentioned. Last night we had the celebration of the 70th anniversary of the arrival of the Windrush, and a celebration of the contribution made to the development of the NHS by people from a BME background and of the diversity of our workforce and of the communities we serve. That's important in itself. And no one who was present at that event, I was there only briefly, could possibly have missed the warmth, the energy, and the commitment of the occasion. But there's a bigger truth there too. When we celebrate 70 years of the NHS, we celebrate a successful organisation and a powerful idea. But what we really celebrate is the ability of the people who work in the National Health Service to make a difference to the lives of their fellow citizens. People join the NHS, whether as a clinician or as a manager or as a support worker, because they know that they're joining a team that is dedicated to improving other people's lives. That deserves our respect. Of course, there'll be times of frustration and times when we will fall short. But the unchanging truth of the NHS is that it's built on the dedication and the professionalism of the people who work in it. So my challenge at the beginning of this conference is very, very simple. We shall discuss money, and we shall discuss structures, and we shall discuss working methods. But it's all so much hot air if we don't connect that discussion with what goes on in the surgery and the things that make a difference to a nurse's life. We're all part of the team. We share responsibility for its successes and for its failures. But it's the dedicated professional people who deliver our services on whom our citizens directly rely. And it's our task and our privilege to help them make the difference that they seek to deliver.
Well, thank you very much, Stephen. As Stephen said earlier this year, we commissioned an independent study into the funding needs of the UK's health and care systems for the next 15 years. It was an overtly political act. Our members were clear that they were increasingly unable to meet public expectations, that the constitutional standards in England were not being met, the money didn't add up, and some services were, quite frankly, unsafe. So, looking ahead, the prospects were not good, but the political class, even those who might be sympathetic, seem to strangely have their minds elsewhere. It is amazing, actually. The conference has been going, including Stephen speaking. We haven't heard the word Brexit yet, so well, there is something positive happening anyway. We needed something that would provide objective evidence, not special pleading, about what will face the country over the next 10 to 15 years. And the resulting report from the Institute for Fiscal Studies and the Health Foundation summarises past trends in UK health spending and provides projections for up to 2033 and 34, and as Stephen says, brings social care in as well. The report also sets out options for raising the additional funds needed to meet future demand. We've no doubt it has already informed a political and public debate, and we're confident it has had real impact at the highest levels within government. So to discuss its findings, please welcome the report's editors, Anita Charlesworth, Director of Research and Economics at the Health Foundation, and Paul Johnson, Director of the Institute for Fiscal Studies. Which of you starting? Are you going up to the...
I think we're staying here.
Oh, okay. Excellent. Good. Well, I'll hand over to you. Fire away.
Okay, thank you. How's this supposed to go? Okay, I'm going to struggle without my slides. Can someone fix it? No. Right, well, I'll try it and remember. You've got the slides there. I can
I think
just
that just
remember
moved.
what I'm doing. Oh, it just moved. Hurrah.
Just moved.
No, not again, though. Right, well, I'll try and do it without slides. Try that one. Oh, there we go. It was the clicker that didn't work. The IFS did was, first of all, look at what's happened to health spending over the last 70 years, look a little bit at what that's bought. Anita and her colleagues then did some projections as to how much more will be needed going forward, given what's happening to the population, size, age, costs of medical technology and so on. And then we talked a bit about how you might pay for that extra demand. So I'm going to talk a little bit to start with about the history, then Anita will talk about the future, and then I'll do the miserable bit about how we have to spend lots of money, or where we might get the money from to cover that. But what you have there is a very striking chart showing what's happened to spending on health over the last 70 years or so. The darker line is spending in pounds billions in current day terms, and you can see that over the 70-year history of the NHS, we've moved from spending less than 20 billion a year back in the 1950s, in current day prices that is, to about 150 billion a year now. So it's an average increase every year of about 3.5% year on year over that period, including that period at the beginning where spending was rising really very slowly given the state of the public finances and the economy post-war. The green line you see there is the fraction of national income that goes to health. And that's what really matters. That's the share of the national cake that gets taken up by the health services. You can see that's significantly more than doubled over this period, and we're now spending more than 7% of the entire national income on publicly provided health. If you add privately provided health and social care into this, you've got considerably more than £1 in 10 created by the economy going just on health and social care. So the key two messages from this are, first, that health is extremely big in terms of spending, and secondly, that over time, the amount we've been spending on it has been rising fairly rapidly as population demands have grown, as the population has grown and aged, as technology has got better. But what this chart is showing is that what's happened over the last 8 years or so has been historically unprecedented in terms of the last 70. Growth has averaged less than 2% a year over the last several years. In fact, not much more than 1% a year compared with that 3.5% a year over the whole period. This has been, as I'm sure you're all aware, the tightest period for spending on the NHS in its entire history. Now, spending has risen, it's just risen a lot more slowly than it has done historically. And in a way, it's risen even more slowly than it looks. So that black line is showing you how spending has changed in total over the last 8 years, and it's risen by about 10%. That doesn't sound too bad, but when you take account of the size of the population, the amount per person being spent has gone up by less than 5%. And when you take account of the fact that that population has overwhelmingly grown at older ages, you age adjust it, you find that essentially spending hasn't grown at all. It's grown by 1% over the last 7 years. And that really is completely unprecedented in the history of the NHS. Essentially, to have real spending per person, once you take account of the age of the population, just hasn't changed over a 7-year period. We've never had a period that's even remotely like that. But this is the chart in a way which concerns probably the Treasury and government more than anything else, which is whilst that has been the tightest period imaginable in the period in terms of spending on the NHS, it's actually looked pretty generous relative to what's happened to all other bits of spending. You can see the green line there is spending on the NHS as a fraction of total public service spending. And that's risen from about 10% of total public service spending in the early 1950s to 30% today. It's easily the biggest thing that government does. And what's very striking about that green line over the last 7 or 8 years is it's actually grown faster over the last 7 or 8 years than it did over previous decades. And that's because while spending on the health service may have grown slowly, spending on everything else has been cut. So spending on health as a share of the total has actually gone up really quite fast over the last several years. There's a very contrast, a significant, big contrast here between health and social care spending. On the other hand, health spending has gone up at least, social care spending has actually gone down, both in real terms and as a fraction of national income over the last 7 or 8 years. So whilst the health service is tight, what's happening in social care is considerably tighter still, and the scale of cuts there, which range in different local authorities, certainly up to and beyond 20% in some local authorities, is on a different scale to what's been happening in the health service. Where does all that money go? We've got a big discussion of this in the document. We'll just talk about it briefly here. Most of the biggest fraction of money, as Stephen Dorrell was suggesting in a sense, goes on staff, because staff are what make the NHS work. But the composition of those staff has changed a lot over the last 20 years or so. So we've got a lot more hospital doctors than we had 20 years ago. We've actually got fewer GPs than we had 20 years ago. And you see that over the last 7 or 8 years. When you look at where the spending has gone, actually spending on primary care, spending on GPs, if anything, has gone down, while spending in the hospital sector has gone up. So we've had a rebalancing away from GPs and primary care towards hospital care. And that fall in the number of GPs as the population has grown and aged, you can see in a lot of the data about problems that people have on the primary care side. On the upside, there's extra money. There's also an awful lot of extra activity. The NHS is doing a lot more than it used to. I mean, this is just telling you how many, what fraction of the population at each age actually have an inpatient admission, comparing 20 years ago with today. You can see that at all ages, people are more likely to go into hospital for some kind of procedure today than they were in the past. The NHS is doing a great deal more, and it has continued to do more over the last 7 or 8 years. The last 7 or 8 years has been a period of significantly growing productivity within the health service, something that we haven't necessarily seen over all periods. And actually, particularly unusually, productivity in the health service over the last 7 or 8 years has grown more quickly than productivity across the rest of the economy. And on a whole series of measures, we are more effective, not just because of the health service, but as a result of all sorts of changes. Things are getting better. Longevity has increased in general. This is just looking at mortality from cardiovascular disease. Satisfaction rates are also significantly higher than they have been in the past. You can see the top line there is the fraction of the population who say they're satisfied with the NHS. It's beginning to dip, but I think it's really important to be clear, it's much higher than it was 20 years ago, before the very big increases in funding that we saw over the last Labour government. But that green line starting to move up, the proportion dissatisfied is rising as waiting lists are rising, as access to GP services are becoming more difficult, as the funding squeeze is beginning to bite. And now Anita will say a bit more about funding going forward.
Okay. So obviously it's the 70th anniversary, so we've looked at what the pressures might be out to the NHS at 85, so that's 2033, 34. And Paul mentioned the ageing of the population, and we've talked about the fact that we've got an ageing population and we need to plan for that. I guess what's really struck me through this work is that the ageing of the population is now upon us. Very, very substantially. So over the next 15 years, and this is looking at the UK, population of the UK increases by around 6 million people, Almost 4.5 million of those are over 65. There are, in fact, almost as many over 85s during the next 15 years as there is the increase in the working age population. Yeah? So we have a period of very substantial ageing of our population. Now, ageing is a challenge, but critical to the impact of ageing on the health service is people's health status in old age. And the second thing, which obviously anyone who is involved in healthcare sees as their lived experience every day, is that alongside the ageing of the population, we'll have the very significant increase in chronic disease, and in particular multiple chronic diseases. So what we've looked at here is for people aged 65 and over, the growth in admissions for people with chronic conditions. And what we see is there's been a significant increase, a 60% increase since 2003-04 in the number of people admitted to hospital over 65 with a chronic condition. But it's 220% increase, and more than doubling for people with multiple chronic conditions. And so it is that multi-morbidity which is really starting to impact. And what we did in our work really is to look at what happens if that pattern of multi-morbidity continues on. And I mean, there's very little basis to assume it won't, I think, from the work we did. And if we continue to deliver care in the way we're currently configured, with that growing and ageing population, with a rising burden of chronic disease and multi-morbidity, the implication of that, our projection is, that hospital activity would need to increase by 50% over the next 15 years. That's no improvements in quality of care, no improvements in the range of services that the NHS is providing. This is current model of care, with the ageing of the population, expanded population, and multi-morbidity. We do not have capital plans or staffing plans to allow us a 50% increase in hospital activity. Now, I would say most of us would not think that maintaining the current model of care is the goal of the health service for the next 15 years. But the transformation in the model of care that you would need to shift those resources to make sure that you don't have a 50% increase in hospital activity is enormous. And the other thing I think then is really important for the NHS we need to be realistic about is what does success look like here? If we did an amazing job at delivering new models of care, the idea that we're actually going to cut acute capacity when actually what we're faced with is potentially a 50% increase seems to me very difficult to evidence. So I think whatever you take away beyond the money, one of the really important things that everyone in the NHS needs to think about is if we were to get additional resources with the 70th anniversary, the change agenda that is implied by the ageing of our population and the rising burden of chronic conditions is enormous. And I don't think we are anywhere near a transformation agenda that could deal with this sort of pressure at the moment. And when you think what we've done over the last 20 years, whilst talking about delivering services in new ways, is cut the number of GPs and increase hospital doctors by 70%, we don't start from the best point here. What that means then in terms of cost pressures, and now just to focus down on England for a moment, is that if you take the current health budget in England, which is about 128 billion, I look at the total health budget, not just NHS England, demographic pressures at about 21 billion. There is additional input cost pressures from new medicines, from additional staff costs, obviously. There is some scope, obviously, to offset that by productivity, as Paul talked about, but you are faced then with total spending pressures of increasing over that period. Those numbers are predicated on maintaining the current offer for the NHS. And obviously the current offer for the NHS is something that people are very proud of, rightly, but we also know there are issues with that. At the moment, we're not meeting NHS constitution standards. But beyond that, if we look more fundamentally, we've got some key issues around our cancer survival rates, which have been getting better, but are still not in line with our peers internationally. We've got a huge issue around mental health and lack of parity of esteem. We've got issues with primary care. We underinvest in prevention, and we've underinvested in capital. If actually we tried to put some of that right, this is not nirvana, but some of that right, we talk about that as a modernised NHS. And so what we get in terms of spending pressures is over the 15 years to maintain the service as is, in the face of all that demographic change and chronic disease, we'd need 3.3% a year over and above inflation in England. For some modernisation, we'd need just over 4%. But what we'll argue is that given all of the issues in the NHS at the moment and the need for radical transformation, I would argue, in order to provide the sort of service that we would want in 15 years' time, not simply more of the same, that some of that needs to be front-loaded over the next 5 years. And we would need an absolute minimum of 4% a year over the next 5 years, and ideally you would have something closer to 5% a year. And we would argue that that needs to be quite capital intensive. So when you look at the UK as a whole then, status quo, maintaining the current quality and access to care in the face of demographic challenge requires 3.3% a year, modernising 4% a year. In one sense, those numbers are pretty modest. I haven't slept for quite a long time to do this, and done a huge amount of work to come up with essentially numbers that are basically, if you carried on the trend of historic growth prior to the recent period of austerity, you get broadly similar numbers. The problem is that those percentages, because the NHS is so big, add up to pound signs, which are enormous. And that is the challenge that Paul's going to come on to. Just to emphasise then, in our modernised NHS, what we have focused on here is not just more of the same, but really trying to make sure that we do invest in areas that we know are really important to deliver a healthcare system that delivers high value and really does meet the needs of the population. So we have factored in a significant additional investment in mental health to get from the situation at the moment where just 4 in 10 people with a mental health condition get any help from the NHS, a position which, if that was any other physical problem, would be considered an absolute national scandal, to a position where 7 in 10 get some help. I think most people, if you ask them in the public, would think that was a pretty minimal offer in 15 years' time. It costs a lot more money. In one sense, it's ambitious. In another sense, it is doing the basics. An increase in capital investment and a prioritisation on public health as well. As I said then, what that means in terms of funding is, if you do look back, and as Paul showed, the average increase is 3.7% across the 70 years. But the last 8 years have been very anomalous, at around 1.5%. So prior to those 8 years, the average was 4%. Really, what we are talking about in this work is returning to something like that historical rate of increase. But it does see healthcare spending grow substantially as a share of GDP, from around 7.3% at the moment up to somewhere between 9 and 10%. And that's the NHS. The position for social care, which has obviously had a very significantly more challenging funding settlement for the last 8 years, is that also needs to increase by around 4% a year before you've even begun to think about reforming the means test or increasing eligibility. And most people at the moment would argue that our current system is not fit for purpose. So this should be viewed, I think, on social care as a minimum. So if you're going to remember anything, it's 4%, okay? 4% for the NHS, 4% for social care, okay? Paul will explain how you need to fund that.
Thank you. I'll do that very quickly. I won't run through all of the possible tax rises that you could put in place to fund that, because there are an almost infinite number of them. Just to reiterate the numbers here, we're looking at needing an extra 30 billion or so by the early 2020s, more than 50 billion on a modernised scenario by the mid-2030s. How do we pay for that? Well, let's look at how we've paid for it in the past. And this is a really striking chart, I think. The bottom line there is health spending as a fraction of national income, and the top line is public spending as a fraction of national income. And the story there is that we've managed to increase health spending without increasing total spending. Okay, for 70 years, we've had this extraordinary situation in which we've increased the size of the welfare state, health and pension spending and social security spending, whilst keeping total spending, and therefore the tax burden, essentially constant. Now, how we've done that? Well, we've essentially done it by abolishing defence spending, or pretty nearly. You can see that the health line goes up and the defence line comes down. There are other things going on here, of course. We're also spending a lot less on industrial support, housing, and some other bits of government spending. But if you look to the past, the lesson of the past is we've been able to continually increase health spending, and we've paid for it by cutting other stuff. And that's also the story of the last 7 or 8 years. You can see health spending there since, actually over the last decade, since 2007, health spending today is more than 25 billion more than it was back then, and there have been cuts in a whole range of other things. There is no scope that I can see to continue increasing health spending by cutting other stuff. Defence spending is already down at 2% of national income. If anything, there are pressures to increase it. There is no scope for cutting local government spending further. There's no scope for cutting spending on the Home Office, where spending has been cut dramatically. There's no scope with an ageing population to make significant dents in what we spend on pensioners. There's no scope, I think, really within the working age social security system, which has been cut really significantly, with some more big cuts coming down the line. In the short run, we can borrow more. In the short run, you can always borrow somewhat more. That will be inconsistent with the government's manifesto commitment to get to budget balance by the mid-2020s. But more importantly, if you're looking into the medium run and you look at the numbers that Anita's been presenting, you can't just borrow more and more every year as demand increases. In the end, you have to pay through tax. And if we're looking at an extra 1 to 2% of national income spending on health, and we can't do that by cutting other things, then we're looking at an extra 1 to 2% of additional tax revenues. That's 20 to 40 billion plus of additional tax revenues. Now, is that plausible? Well, yes. If you look here at the UK tax as a fraction of national income against a whole bunch of other G7 and European Union countries, the current UK situation is the darkest bar there. We are a relatively low tax country. It may not feel like it when you see the tax coming out of your pay packet every month, but we are a relatively low tax country. If you pay for the additional amounts that Anita described, that takes us on current levels sort of somewhat up, but still below most EU and G7 countries. So from a macroeconomic perspective, you can run an efficient economy with a higher tax burden than we have at the moment. There are all sorts of options as to how you can pay that. Looking at the scale of this, it is hard to see how you do it without increasing one of the big three taxes: income tax, national insurance, VAT. Between them, they raise about 2/3 of all tax revenue. Getting an extra 30 or 40 billion without doing something to one of those is pretty challenging. Of course, you don't have to do that in the short run. There are other things you can do in the short run, but in the long run, taxing people's income or spending has to be part of the story. I won't say any more than that. There are all sorts of different ways you can do it, and I could spend hours telling you about all of them, but I won't.
Okay. Thank you very much to Anita and Paul. I'm going to ask, let's give them a thank you very much. We've got some roving mics around the place, so if you could put up your hand, we'll get people with a paddle will we'll come to you. While we're just getting people organised on that, just to focus in on that 4% figure for either of them, is it fair to say that this is not a radical manifesto, as it were, because I think the description of the 4% may come back from other sources as being, this is ridiculous, it's more than, it's just unaffordable and all the rest of it. But in terms of what it would do, it's only transformational to the extent that we have to do an awful lot of very difficult things to get there.
Yes, I mean, I think actually the transformation agenda around 4% is that to live with 4% and to be able to improve areas like mental health, to deliver the sort of outcomes that we'd want to for people with long-term chronic health conditions, we need within that to deliver a very different model of care. So actually, living with 4% means really fundamental changes to some of the ways in which we deliver care. And it will be, and so the thing that for me was most stark about the analysis that we did was just how much funding you need to meet the basic challenge of aging and chronic disease, and that pressure, so that there's very little headroom then for real improvements in quality. So we will have to be very disciplined and very focused about, if we got something like 4%, about where we invested the little bit of extra money, if you like, to deliver improved gain. The other thing is this does need quite significant increases in staffing, but there is not money in here for a pay bonanza. So the workforce implications and the skill that's going to be needed in the NHS to manage the workforce, we cannot rely on large pay increases to improve recruitment and retention. We're going to have a workforce policy which is very clever to make sure that we use all of the tools at our disposal to manage recruitment and retention. Because there is, we have assumed some pay increases, but this is not a pay bonanza, and we would need to take a bigger share of the overall workforce. So, there's a real workforce challenge within this, and the areas of the workforce that we need are the areas of the workforce that we've been really bad at getting. Yeah. So, we need mental health workforce, that's going backwards. We need a nursing workforce in the community, that's going backwards. And we need a GP workforce, and that's going backwards as well. So the change agenda within here is, I think in the end, getting the money is going to be hard, but it's likely to be the easier bit than spending it well. But the onus on us to spend it really, really well, for me, if we were to secure this money, and it will come out of people's pay packets or people's income, not necessarily the pay packet, people's income, and it's a significant tax impact over 15 years. There's no getting away from that. The onus on us to spend that money really well, the priority to productivity actually gets greater rather than less. And we will not get increases again if we can't demonstrate that we're spending it really well.
Okay. Microphone 1.
Good morning. It's Colette Goldrick from the Association of the British Pharmaceutical Industry. First of all, Paul and Anita, congratulations on the report. I think it's making a hugely important contribution to this debate. I'm going to be really cheeky and go for 2 questions, one on the getting and one on the spending. Paul, we've seen from recent polling that the electorate is quite positive about the idea of more taxation going towards the health and care service that it wants to see. But yet hypothecation, which is probably the only way of actually securing that, is of course an economically inelegant solution. How likely is it that the electorate would be as keen on tax rises if it had to rely on the politicians to put them in the right place? That's the question on the getting. And then with regard to the spending, Anita, to your point, assuming that additional funding is secured in order to deliver not just an okay health service, but a world-leading health service which is capable of co-creating and utilising innovation, how do we avoid that increased funding being salami sliced so that all the critics who say money given to the NHS is water poured on sand, how do we avoid that happening?
Okay. Well, I mean, on the issue of hypothecation, I mean, there's been a lot of discussion about this, and it may be the only way of persuading people to pay more tax. But just to explain very briefly why you've described it as an economically inelegant solution, you cannot have a tax which is hypothecated to the NHS and then spend just that amount on the NHS, because taking as an example, people were talking about this back in 2008 when national insurance contributions were almost exactly the same amount as was spent on the NHS in 2008. And so you could have thought, well, this is a good moment to hypothecate national insurance to the NHS. Over the next 3 years, the revenue from national insurance contributions went down and spending on the NHS went up. And had we had a pure hypothecation system, we would either have had to whack up tax during a recession or cut NHS spending at that time. We clearly wouldn't want to have done that. Now, there are ways around that. You can borrow and you can borrow across periods, and then you get something terribly complicated and probably even less transparent than you've got today. There are other forms which are things you can call hypothecation. We can just say we're going to put a penny on NI or income tax or something and say we'll increase spending on the NHS as a result of that. That obviously works in the short run. It means nothing really in the long run in terms of hypothecation. So you can use that as a political way through, but it's not in any sense, I think, real. To what extent are people really prepared to pay that? I don't know. But if, for example, just looking over the next 5 or 6 years, if you were to pay for that extra 20 or 30 billion through putting a penny or two on income tax, that's several £100 a year for people on average earnings. Now, in the short run, you can put a bit more on corporation tax, you can do a little bit more for the highest earners. In the long run, the numbers are so big that it has to be a fairly broad-based tax increase.
Anita.
Yeah, so I think one of the key things here is all the speculation is that there'll be an announcement on funding before the 5th of July. If there is, I think, obviously that'll have been a very quick process. The key thing then, I think, is not to rush the process of really doing the work to think about how we're going to spend it, and to make sure that the process of thinking about how we're going to spend it is a really inclusive process, and that the results of that are really transparent and they're tangible things that people who work in the service, and let's remember, it's about 1 in 10 people in work who work in the health or care sector. Yeah, so we're also a huge part of our staff are a huge part of the population as well. So involving people and being very clear about what we're going to do with the additional resources and what the changes are therefore needed to deliver that improvement, so that there's very strong public and staff engagement in that process. For me, that will be absolutely critical to being able to spend this well, and also for people to be able to see the impact. And the final thing is, whatever we do with it, we have to avoid 3-letter and acronyms for it. We have to speak in English.
Okay, I'm going to take, there are 2 people there, I think. I'll take them both very quickly. So one, then the other, and then a very brief response from the 2 of you. Thank you.
Hi, it's Jim Easton. I'm currently the Chief Executive of Care UK. I previously had a national role with a bit of an anorak interest in this subject. So I think it's a brilliant piece of work by Paul and Anita. I think it's probably unanswerable for government, but it's also unanswerable for the people in this room, and that we need to hear really clearly the call for change. And actually our track record is not that strong for all our brilliant work on the kind of change. I think you said it clearly, but it may not be heard. So what do we need to say to Treasury to convince them that we mean and can make those changes? Because they're not wrong to be sceptical based on history.
Okay, thank you. And then last question, the lady here. Thanks a lot. Very quiet over this side of the hall.
Thank you. Hayley Richards, AWP Mental Health Trust. Thank you. I certainly recognise the point about mental health workforce going backwards. And in spite of the investment we've had in mental health spending recently, we're starting from a really low baseline. As a provocation, is it time for a truly and genuinely ring-fenced boost to mental health spending so that we can get the advantages of integrated work out of the mental health workforce?
Okay, very brief comment from both of you.
Let me just talk very briefly, say something very briefly in response to the question about the dilemma for the Treasury. I won't talk about it in terms of the reform in the NHS, but the Treasury is stuck in a bind here, and you've got to feel a degree of sympathy for them, actually, which is that they know that, you know, this money is needed. They know they're going to really struggle to get any tax rises through essentially a hung parliament. And they have a manifesto commitment to balance the budget in the early 2020s. And they also know that they can't cut money from anywhere else. Something there is going to have to give. They're either going to have to raise taxes or they're going to have to basically chuck their manifesto commitment out of the window. And all of this in a context where they've got no idea what the economy is going to be doing in 3 or 4 years' time, and they're frankly pretty worried about it. So that's the dilemma they face. And, I mean, let's feel a little sympathy for them.
Anita.
Well, I mean, I think the point that I would just emphasise over and over again is that I think the really important thing, if we were to get the money, is the step up in leadership from everybody across the system to really own the responsibility to deliver tangible improvements to the public and real value through improved productivity. And I would like to hope, actually, that we didn't need to ring fence mental health or public health, that actually we took that seriously. You know, ring fencing is always a second best solution, but it is very depressing to think back that actually one of the few real improvements we got in services through IAPT was because we ring-fenced it and we pushed it through the system. So actually, if people don't want it ring-fenced, then actually the leadership challenge is to really focus on showing that we can make a reality of those commitments without being required to.
Okay. Now, just before we say thank you to Anita and Paul, just have a quick look here, and we should see, I hope, coming up an Ipsos Mori poll. I'm pressing the button. Well, that's Paul's given me the dud one, hasn't he? Ah, you did. You did give me the dud one. So we asked 1,000 members of the public for their view about this. So 77% supported a 4% spending rise for healthcare over the next 15 years. Whether that'll be any solace to the Treasury, I don't know, which would enable the NHS to make modest improvements. And the support for social care, around 4%, again, funding required to meet the needs of an ageing population. 82% supported that. And then in terms of support for how to pay for it, slightly lower figures, 42% pay more income tax, 45% increase national insurance, 23% increase government borrowing. We have at least started the debate, I think it's fair to say, on that front. Can I ask you to thank Anita and Paul very much indeed? Thank you both. Okay, the other side of the funding coin, of course, as we've just heard from Jim, is this question of transformation. I think we all accept that even with more funding, the system's not going to thrive and may not survive if we just do more of the same. So how do we reshape our 20th century model towards something that's more 21st century? To answer this, I'm joined by an illustrious panel with Owen Williams, who's the Chief Executive of Calderdale and Huddersfield NHS Foundation Trust and a trustee of the Confederation, Erik Nordkamp, the Managing Director and Head of Global Innovative Pharmaceutical Business at Pfizer, Councillor Izzi Seccombe, the lead member for Community Wellbeing at the Local Government Association, Dr. Amanda Doyle, who's the co-chair of NHS Clinical Commissioners and ICS lead for Lancashire. But first, to set the scene, NHS England's National Director of Operations and Informations, Matthew Swindells.
Well, thank you, Neil, and thanks for the opportunity to join this illustrious panel. The title is Integrate or Disintegrate. I like to think that a system is for life and not just for Christmas. Across the NHS, we're seeing systems forming. We are seeing STPs becoming more effective. We're seeing ICSs taking on leadership. A smaller example of that has been this year's contracting round. This time last year, on my desk, I had about a dozen contractual disputes between CCGs and their local providers that have worked their way all the way through the regional structures and had ended up being arbitrated centrally. This year, none have made it as far as my desk. The systems have sorted this out for themselves. People have focused on trying to solve local problems, whether they are what we would call our most advanced systems or even the ones that are still forming. But we're now in a position where across the NHS and across the care system, we need to accelerate that partnership working. Whether we receive the more money that the case has just been made so compelling for, and we have the opportunity to be significantly rethinking the next 20 years worth of health and care and building the future of a population health-based NHS, or whether we are disappointed by the settlement and we are still trying to get from one day to the next. The only way forward is to be working in partnership. The only way forward is to be placing the patient at the centre of our design. And the only way forward is to be eliminating the unnecessary duplication that we currently see. So when we look across the best systems around the country, when we look at what is happening in their designs, what we see is that they have turned the concept of sustainability and transformation partnerships upside down, that they are starting not with a top-down bureaucracy, how do I sort out the governance and who's going to get to sit on a committee and should it be on Wednesdays or Thursdays. They are thinking about the local areas, they are thinking about neighbourhoods, they are thinking about networked GPs coming together to address long-term conditions and care management and prevention, and delivering extended access and support for care and nursing homes, and focusing on how do we make the people who work in primary care and community services lives better and more productive and more positive. And at that neighbourhood level, at those networks of primary care, we are seeing innovation happening every day across the country. And those networks are coming together at a place level, usually around the boundaries of a local authority, a footprint that makes sense to local politicians and local communities. And at that level, we're seeing primary care, community services, mental health, acute services, trying to focus on the needs of a town or a borough. But we're also seeing that close working with local government starting to come together around police and housing and education and social care. And when I travel around talking about what systems and integration means now, what I'm hearing are people talking about the Barnsley pound and the Bradford pound and the Blackpool pound and the Bournemouth pound and the Blythe pound, and how do we align ourselves to deliver the care that the people of our areas need, and a focus on place and system working at a place level and the integration of services around the growing needs of patients, ageing populations and people with chronic conditions. And as they come together, the role of an STP is therefore not to be the centre of gravity for every great piece of thinking, but the coordinating and the performance management and the strategic development of what do we have to do at a higher level that you can't do at the level of a borough, and how do we make sure that best practice is flowing, and how do we make sure that we think about the bigger questions of population health and acute provider design and community design, services design, and what does our workforce need to look like across a wider population, and how do we align our IT strategies so that we are not duplicating IT systems, but that we're learning from the best, that we roll out our global digital exemplars across the whole of a system. How do we make sure that our local health and care records really are care records that are designed to allow us to support patient care? And so increasingly what we're seeing is those systems coming into place, and we need to jump to that everywhere now. We are now at a point in time where we can no longer think about this as a bold experiment and start to believe in it as the way in which we work going forwards because we're seeing the benefit. And I've talked about this on occasions as being a bottom-up reorganisation. Well, the fact that NHSI and NHSE are now having to reorganise in order to fit with the demands of the service rather than the other way around, I think is a nice playthrough of that. But we're going to see increasingly this year the rubber really hitting the road again for systems, the need for us to be thinking at a system level if we're going to make changes. Many of you will have seen in the news or in the Health Service Journal or landing in your inboxes today the letter from Simon and Ian about the 2018 capacity plan, the need for us to drive through improvements in length of stay in order to be able to hit our elective and emergency ambitions and be prepared for the winter. And we need to think about that not as just as a productivity improvement, but actually as a moral imperative. Because what we're really talking about are long-stay patients in hospital, receiving care in the wrong location, having their liberty deprived, who could be cared for in another location. And Ian, I'm sure, will talk at length about the challenge for hospitals, and if you think about the 2015 Nuffield Trust report, the 50% of the patients unnecessarily in hospital are within hospital's power to deal with. I'm interested in the other 50%, the 50% that require a system to come together in order to get patients the care in the right place at the right time, that requires primary care and community services and social care to come together to do a combination of emissions avoidance. Nigel Edwards' report again has talked about the 20 to 25% of patients who are admitted to hospital who, if the right services were designed in the right place at the right time, would never have gone into hospital in the first place. And also the better discharge. We've seen fabulous work across NHS and care in the past year around delayed transfers of care. The 1,700 beds that you released through that joint working allowed us to survive the pressures of last winter, the worst flu epidemic for 9 years. We need the other 900 beds that were part of the plan last year. We need to continue to accelerate that working together to get patients to the right locations. But we also need to go further than that. We need to be working together to address every patient who is inappropriately being cared for in the wrong place and help get them to the right place. Simon Stevens announced a few weeks ago his ambition to see community trusts looking at patients who were seen as excess bed days in hospital. Patients who hospitals are being paid to look after because they clearly shouldn't be in hospital. They should be in their own homes, they should be in a care home, they should be in a community trust. We've got 7,000 beds or £600 million worth of spend attached to excess bed days. If we closed by 1/3 the gap between all areas and the top quartile in terms of excess bed days, it would release 1,000 beds and save £70 million. What I want to see is CCGs and SDPs working together to say, how do we get that money that we're no longer having to pay to acute trusts because we don't have excess bed days into community services so that we can expand and grow and develop our community services, because we need that piece of the puzzle to shift the balance of the expenditure that Anita talked about earlier, about the constant investment in acute services, whether it's right or wrong. We need to start to focus on a 7-day NHS, one which doesn't admit for 5 days a week, admit for 7 days a week and discharge for 5 days a week, but is thinking at all points in the pathway what is the right thing for the patient. Because systems are today's challenge. They are our ability to work in partnership, but in a really disciplined and focused way to deliver change, is both to deliver the challenge of today and be in the right place, that any money that we get in the future we spend well, we spend to the benefit of the nation, we spend to the benefit of the individual. We have seen over the past couple of years necessity being the mother of invention. We have seen the degree of innovation that people have put in place in order to cope with the pressures that the NHS is currently under. We need to see that as the basis for sprinting forward to create the new and better NHS in the future. And I'm confident that the progress that we've made in the last year will see that integration of care, that focus around the individual, that design around real need rather than around institutions, puts us in the right place to go forward. Thank you very much.
Thanks very much indeed, Matthew. Owen, if I can begin with you, are we going at the right pace?
I think what I'd say is, given the context in what we're in right now, we're probably going at a realistic pace. I think the question I think we all need to think about and explore is, how do we accelerate the pace? And I think Matthew's right to point out, I'm a part of the West Yorkshire and Harrogate integrated care system, and it is right, there's a real sort of bottom-up feel, people are coming together and having conversations. But I think the question about how we maybe accelerate the pace and how we get the joined up and connectedness still remains unanswered. And I think part of that is because a major component of that is going to be particularly how we have regard to what I call the digital agenda, and in particularly digital interoperability. And there's a sort of thought process in my head. It's a bit like, imagine Amazon just running on paper. You know, just let that thought settle for you for a minute. It's just impossible to imagine, isn't it? You know, technology plays a role in that. But if I was to ask the panel and ask the colleagues out there, when last were you in a board discussion where you discussed digital interoperability, how you were going to connect patient data information, not just within your organisation, but across a local authority, across a CCG? I suspect I might know the answer to that if people are willing to make a declaration of interest.
Well, let's ask them now. How many people say in the last 3 months have been in a meeting which has considered that issue?
Okay. If I just say, I'll exclude cybersecurity conversation and GDPR, and then ask people to stick their hands up again, I wonder. And I think that's just the point I make. If you want pace, we need to look at the things that connect us, and digital plays a role.
And do you think that Matthew talked about all those initiatives, and particularly, and you referred to them as well at local level, do they add up to enough to alter that dial to actually start relieving the acute sector, to start to sort of change the fundamentals of our system?
I think what we've seen in the last presentations is some really powerful narrative that says, even with some of that energy, we're going to have to go some to make that shift. So I would say it's probably a version of maintenance, probably some improvement, but if we're talking about the language of transformation, I would argue that we've still got some way to go in terms of how we collectively work together.
Okay, let me get Izzi now. Just in terms of local government, when SDPs first came in, I think had a kind of took a deep breath and said, don't really feel we've taken part in the construction, not really sure that our role is fully understood. Has that got better?
I think a mixed bag, I suspect. I think we can say that there are some really good examples of joined up working going on, of a real vision for their area that is being rolled out, and that both sectors are coming together to actually try to plan very much what you were talking about, Matthew, this place-based approach, really making it mean something to the local community, the local area, and how the integration can work in the field right at the front. But too often we've seen the STPs really have been very much more focused on actually the savings that need to be achieved, but not the vision of place shaping and trying to actually integrate the system to improve the health and well-being. And I think it's also significant that we need to recognise the wider contribution within local government, which isn't just the social care element. And we heard Stephen talk about it earlier, talking about housing, talking about leisure offer. All of these will contribute towards making the well-being of people's lives and that growing population that we've heard about just now, making that something that isn't going to be a drain on our resources, but is actually meaningful and takes into account what people want in their lives.
Amanda, how far in your ICS is there a tension between the time that you need to spend on the fact that the books don't really balance and you're trying to do all this stuff that Matthew's talked about, which is change the agenda?
So doing all this stuff is going to enable us to do something about the fact that the books don't really balance, and we've got a huge gap before we can balance our books. But actually, continuing to behave and work in the same way that we've traditionally done isn't enabling us to address that. So there is, as Matthew says, you know, we're looking much more at how are we getting the most effective use of the resource we've got and moving away from traditional approaches to payment, for example, traditional approaches to planning and our financial strategy, and taking a much more collective responsibility for making our books balance. So we now across Lancashire and South Cumbria, and this is across both commissioners and providers, have a collective financial strategy, a collective approach to what the system financial position looks like, as opposed to 20 or so separate organisational approaches. We've got to start working in these new ways, and we've got to start changing the way we work to make it fit how we're trying to develop our system. So there are things we are very much doing and transforming at that neighbourhood level, 30 to 50,000 population, GP practice, voluntary sector, the community, local government. There are things we are doing at what we call ICP, Integrated Care Partnership level, which is largely a health economy, a trust and out-of-hospital services and general practice and a population and the services we deliver there, and service redesign and planning and some of the clinical service transformation is happening at that level. And then there's how we do things at the whole ICS level, 1.7 million people, and what's our strategic approach to use of resource, and achieving a whole system approach to both finance but also performance.
And what do you say to somebody who's maybe sitting in what feels like a very different SDP, as it were, where there are still real tensions about organisations that are in deficit, that feel the accountability from the centre and so forth, and where it's much more difficult to get to or appears much more difficult to get to the kind of place that you've got to, accepting your place isn't a good one, as it were, it's that you're managing through it.
So, I think what really enabled us to start changing in the way we work was the realisation that no one either place or organisation was either clinically or financially sustainable in its own right. So we're not a patch with a big successful trust that was fine, thank you. We've got challenges across the patch. And so actually the only way to address that is to make yourself sustainable as a system. And we're a long way from being there, but we're moving in the right direction. You can only do it at the moment if everybody wants to. And that is, the challenge is getting everybody to want to and everyone to start to work in that organisationally agnostic way. And that's really the thing I'm most proud of in Lancashire and South Cumbria, because we have made huge strides in that. We've still got health challenges, we've got health outcomes challenges and clinical outcome challenges, massive workforce challenges and a financial gap. But actually we're putting ourselves in a position to do the best we can about that and make a difference for our patients as well. We are starting to see some clinical services which are wrapped around patients in a much more meaningful way once we take out that competition element of things.
Erik, what's your perspective on all this, and any pitfalls that you can see?
Well, from my perspective, I mean, from my company perspective, and then also from my perspective, sitting on the board as a net in a trust in London, I would say I always start by saying there's probably three dimensions that I look at this at. One is looking at your daily operations when you're in a trust or a healthcare organisation, and say, where do I have my demand? And if I look at that silo, is that actually profitable or is it not profitable? And can I correct or rebalance some of that? The second dimension is then very much the discussion that has been had here, which is the integration in the local health economy, which is really where most of the discussion has been so far. And absolutely, there is a need to do that. And certainly as a company, we're partnering in that area a lot, thinking about treatment pathway redesign and things like that, where you basically create win-wins for everybody. You create a better experience for patients, for healthcare professionals, you create better outcomes, and you take cost out of the system. And the third dimension, which is the dimension that doesn't get often talked about, but is equally important, especially in the Brexit context, is the transformation to be more open to all of the possibilities that are out there globally in terms of the new technologies that are there. And I'm not talking only about medical technologies, as you would expect me to do probably, but digital, med tech, and all of the other things that are going on that really have the potential to completely transform the way that we do healthcare. And this is another sort of partnering possibility and opportunity that people need to be open about. So when you think about sort of pitfalls, I'd rather would think about getting the incentives right to make sure that people, and especially the leaders in the healthcare system, role model things in the right behavior and keep each one of these dimensions in the back of their mind. And I was discussing with Owen just before we went up, you know, how much headspace do boards have to really think about the last two dimensions that I was talking about. And from my own experience, it's not enough, you know, from what I can see. And what we try to do as a company, and not only as a company but as an industry, is to try and really think with the healthcare system to say, okay, how can we partner with you both on the second dimension and the third dimension? On the first dimension, obviously, it's more of an in-house thing that needs to get done.
Do you think the mindset, I mean, obviously, spoken to a lot of people here are at the forefront of this, but do you think the mindset of the health and care system as a whole has moved sufficiently to understand that we can't solve problems organisationally?
Well, I personally think there's more work to do. The mindset really needs to shift to how can we create a sustainable healthcare system for the future? And frankly, that's a debate that's going on not only in this country but in many other countries. You know, I've worked in 6 of them. And in order to do that, we need to be open to say, okay, if we have challenges that costs are rising, one part can come from the taxman, you know, in terms of cost, but there are other revenue sources that we can bring in terms of making the healthcare system sustainable and benefit at the same time. The life science industrial strategy is a good example, right? There is a reason why that was the first sector that the government picked, because we happen to have one of the most competitive sectors there in the world. And there is a real opportunity to attract more investment that creates possibilities to do more clinical trials, to get earlier access to all of these technologies, to imagine what is possible to make the health system more efficient, etc. And we need to find a way of fitting that into the agenda of the NHS. And that's why it's so important to have the incentives aligned. I'll give you an example. If a trust does a clinical trial, at the moment, it's not necessarily automatic that the funding for that goes into the trust, it goes into the centre. Now, where's then the incentives for the trust to have an agenda at their board meetings to say, okay, how much of our time are we going to spend to try and create an organisation that is an attractive partner to do these types of things? And those are the types of discussions that we're engaged in more and more. And there are parts of the healthcare system where this is really happening. I'll give you an example in Wales where this is public knowledge, where we've partnered with a consortium to say, okay, what can academia, what can various parts of industry do, what can the healthcare system do to partner in completely different ways and rethink what is possible, and rethink in terms of treatment pathway design, rethink what healthcare looks like, and then how are we going to scale that? And this is something that gets a lot of momentum at the moment, gets a lot of interest, and is really where I think post a Brexit environment we need to be and think, to make sure that the NHS is part of making the UK a really unique and differentiated healthcare system.
Okay, thank you. Matthew, just sort of end thoughts, any reactions, but also the one thing we probably haven't touched on, just not because they haven't said it, because I haven't asked the question, is around public involvement and public understanding of this. We're endlessly producing more acronyms which, frankly, the people on the street won't understand who these are. They may know who the local authority is. Is that a problem for us, and how do we build in local accountability into this process? But also any other reaction you have?
Yeah, so I think the general sense, which is we're making progress, we have to go faster. It's hard to go faster when you're working under this much pressure. It's just the reality we're all living in. But I think both Owen and Amanda making the point that there isn't an alternative. So we have to drive this forward. To do the changes that we want, we're going to need the public on our side with it. Now, some of the changes we want to make, the public will be shocked to discover isn't the case already. So it's probably not good. We probably don't need to break to them the news that we don't work as one joined-up team within the NHS. We should probably just get on and fix the problem and talk about how we move on. But there is the transformation of the way that health needs to be delivered in order to reflect the movement to managing an ageing population and chronic conditions will require a discussion with the public about what they think the NHS is. And I was out in Norfolk last week talking to the leader of the county council, and she's talking about how they have taken on the challenges of having to reinvent themselves in their financial pressures. And what they don't spend their time talking about what they're taking away. They spend their time talking about what the new expectation for the public ought to be. And the NHS needs to start explaining what it's going to feel like as a member of the public and why people should demand that, rather than explaining endlessly why it's all about this building that's closing. And I think that's a change in a mindset, and we could really learn that from a number of local authorities who've been kind of even further in the heat of fire over the last few years than the NHS has.
Okay.
Can I just,
yes, please.
On that public thing, so I still practice as a GP, not as often as I would like, but so I see a lot of people, a lot of patients, members of the public, and actually they don't really care that much about what we're busy doing and how we're busy working. They care about whether they can get an appointment, whether they hang on the phone for half an hour at 8 o'clock in the morning, whether there's a risk to are they going to get the medication they've always got because they've read in the paper that there's changes to what we will prescribe? How long are they waiting for a hospital appointment? Are they getting treatments that again, they read in the paper are available? And actually, we need to stop kidding ourselves that people really, really care about us. They care about the services they get. They care about primary care being accessible. They care about hospital waiting times. They care that their granny's on a trolley in A&E for hours and hours and hours. They don't care.
And they care that somebody's accountable for that.
Yeah.
Yeah. Okay. Listen, I'm going to take very quickly, again, hands up. There are mics around if there are questions for any of our panel. And there's somebody over there. So if we can get I don't know where the paddle's gone, but there's somebody there. Could you put up your hand again, who was here? Could somebody come down? Okay, it's going to be number 2. Okay, are there any other hands over here? So, if you can, again, once you've found somebody, please put the paddle up. Thank you. Number 2.
Charlotte Aldrich, Director of the Centre for Progressive Policy, a new think tank. My question is to Matthew, but to other members of the panel, on the changing role of the centre and national bodies and national frameworks, where place is becoming an increasingly strong part of the agenda and taking a real lead.
Okay, Matthew.
So, we are currently working with a system which is almost designed to make it hard to move quickly. And I think the challenge for the centre is both ensuring we maintain a public accountability and that we deliver what the NHS as a whole delivers what's promised, but also getting our feet out of the way and creating the space for places to hold themselves to account. And I think that's a trick we're going to have to learn over the next year or so. And I think some of the changes we're making now are steps in that direction. But I think the whole of the STP movement is a movement towards bottom-up ownership, held to account, as opposed to top-down instruction.
Okay, number 1, please.
Thank you. It's Chris Bourne from Healthcare UK, and we support the NHS to generate partnerships overseas. I'm interested in Erik's comment about looking for other sources of income, because it's, we all know, and we've known that trusts can now generate a whole load of private income potentially, but I'm not sure how much trusts have been able to take that up. So it's a question of how amongst all the pressures, we could also encourage trusts and other parts of the NHS to spend time on how they might generate income. Our example is about how you generate income by working overseas, but there are other examples too. So I'm really interested in how we might help find those sources of other income. Thank you.
Amanda?
So I think all sources of income are gratefully received. What makes me nervous sometimes is that not everybody is equally able to exploit those opportunities, and so what we're getting is big trusts with research capabilities, with huge numbers of specialist services, which are able to take advantage and do that and can, you know, we need our specialist centres, but we've got to do something about how we develop out-of-hospital services, what primary care starts to look like, and how we're going to fund a real significant expansion of those services, and how we're going to get people to want to work in them. Because the issue we've got at the moment is not just the income in those services. The problem with general practice at the moment is not really just money, it's not even at all money. It's that it's not a job that anyone wants to do, and no amount of tricks to recruit more people and encourage them to come along, or things to keep people there, are going to make any difference at all until we make it a job people want to do. And so the opportunities for expanding income, for doing things differently, for partnering with other organisations need to be widened out, and we need to think about it in terms of the whole system.
Okay, just before I go to Erik, can I give you a warning? I'm going to ask you a poll question. So if you get your thing out and get to the next poll question. We've just got two brief questions just to sort of sum up this session and get your thoughts on it. Erik?
Yeah, maybe just to build on what Amanda said. I hope I was not giving wrong ideas that it's only the teaching trusts that need to do this. I would say, from what we've seen, is that one of the things that we are looking for globally, and not only us, but other industries or sectors that are looking at this, whether it's digital, medtech, or whatever, we know that transformation happens in a population of about 3 to 5 million people. And if you look at the Life Science Industrial Strategy, that is really what they're aiming at. You look across the world at regions that are successful at doing that, that's what we're doing. When we're in Wales doing this, it's about 3 million people. And that's why we're working together, not only with a teaching trust, but really with an area where the whole health economy then works together and provides opportunities to do that. But the big thing that needs to really change is that in the leadership's mind, in terms of role modeling, that headspace gets created and this becomes a priority. And that means that it needs to become a priority for the regional health economy. And then collectively, they can start thinking about where do we get those sources of income. And they're not only sources of income that we traditionally think of. There can be other sources of income. Royalty streams from selling your brand, overseas. There are loads of ideas that are floating around. I think it's just making sure that people get the headspace to start thinking about these things, because if 95% of your time is spent thinking about your operational challenges, you're never going to get out of the hole.
Good point. Okay, right. If you can look at your thing. The first question that we've got coming up for you is, when it comes to integration, can we make more progress in the next 5 years than we did in the last? So if you can vote on that now. I'm hoping on the screen it's going to appear. It has appeared. Good. Okay. Wow, the level of optimism knows no bounds. Fantastic. Yes. Okay. The other one is. Either that reflects that we haven't actually made very much progress in the last 5 years. It's possible, I suppose. There are two different ways of looking at that. Okay, all right, let's go on to our second question, which is, how confident are you that your local health economy is in a good position to start the transformation process? You're very confident, you're quietly confident, slightly sceptical, or you're not confident at all. If you could vote on that one now. Okay, that's a bit more sobering, I have to say. Matthew, is that what you'd kind of expect?
Yeah, that's exactly what I would expect. Yeah. But what I would say is the challenge for leadership is to turn C into B. This conference is not a conference of passive recipients of change. This is a conference of people whose job it is to drive change.
Absolutely. Good. All right. Can I ask you to thank Matthew, Amanda, Izzi, Erik, And Owen, thank you very much indeed. Thanks a lot. Thanks a lot. Okay. Good. We're now moving on for our next speaker, who has more than 30 years' experience in the NHS and the wider health sector. He's been Chief Operating Officer and Deputy Chief Executive at NHS England and Chief Executive of NHS North of England, as well as serving time at BT and 2 acute hospital trusts. Since arriving at NHS Improvement, there have been significant moves to work more closely with NHS England, something our members have called for some time. Please welcome the Chief Executive of NHS Improvement, Ian Dalton.
Hello, Neil. How are you? Great to see you. Thank you very much, Neil. And it's a massive pleasure to be here this morning, if slightly daunting. While Neil's very kindly listed some of the elements of my CV, he has reminded me that my first job in the NHS was not the ones that he mentioned, but I think it was around 1984. My first job at the NHS was as a temporary occupational therapy assistant, working with people with learning disabilities in what we used to call a long-stay mental handicap hospital. We not only don't call it mental handicap anymore, and that's a good thing, we actually don't have long-stay hospitals anymore, and that's a good thing too. So what it demonstrates to me is that I have been around the game a fair bit, but that said, not as around the game as long as the NHS that we're talking about today. So as we look to celebrate the NHS's 70th birthday, I believe that in so many ways, we should feel incredibly proud. I know very well just how hard it is to manage services at the moment and the way that that's been over the last few years. I know we've asked you to do extraordinary things, but I think it's really important to put that in context. When we think about the NHS approaching 70, there is simply so much to celebrate, so many great achievements to call out. Let's just take one example and cast our mind back. Let's take life expectancy. I know it's not completely the role of the NHS, but life expectancy has increased by more than 1 day a week since 1948. Or to put it in equivalence, that's an hour over each morning's shift. That is a phenomenal change. And we should all be proud of the part that we play in that. But I think we also know that after 70 years, the NHS is now in need of what I might describe as rejuvenation therapy, so that we collectively can enhance and extend its life expectancy. In reality, I think we all know that the NHS we love was in many ways built for a different era. And I think we need to be honest that in many ways it's now showing its strain. The strain caused by an ever-aging population with ever greater frailty. The strain of seeing an ever-rising demand for services. The facing of the paradox that we're employing more clinical staff than we've ever done before, but at the same time, we've seen medical and nursing vacancies across the NHS reported to us as rising to 45,000. The strain of real financial pressure, with 89 out of 136 acute providers reporting a deficit in their audited accounts, a sector deficit across the providers we have in this country of 960, and erudite commentators telling us that we have an underlying deficit across the provider sector, approximately 4 times greater than that. And perhaps most importantly of all, not always delivering what we want for our patients. I could pick plenty of examples, but I'd merely reflect having come back to the NHS after a few years away recently, that we haven't delivered the A&E standard since August 2014. And we've now got over 2,750 patients who've waited more than a year for elective surgery. I would therefore contend that if the NHS we serve is to survive as this country's most loved institution over the next decade, I think we all know that we need to fundamentally change and improve it, because it is clear that the NHS is at a pivotal point in its history. To give you but one example, if we do nothing, in 10 years' time, the rise in emergency admissions would require us to build the equivalent of 80 new district general hospitals across this land. And we'd have to staff them, and we'd have to fund them. Let me let you into a little secret. We probably aren't going to do that. So we need to find a different way. And that is, I guess, the challenge of this conference and of those of us that are working so hard to make sure that we can. Let's look at some elements of the issues that we need to address. Let's look at efficiency and productivity. On the good side, it's quite clear that the NHS continues to outperform the productivity of the UK economy as a whole, significantly and continually more productive than the UK economy. Providers across the country delivered £3.2 billion worth of cost improvements last year, which was significantly more than they'd ever done before. So there's a lot going on to make the best of the NHS pound, and I celebrate that. But that said, if we look ahead, I think we do have to accept that there are immense and unwarranted variations wherever we look in the NHS, and that these are sufficiently material and real to limit the extent to which we can care for our patients. I don't think that's controversial. I think everybody in this room understands that. I think the question for me is, if we do understand that, what is the magnitude of our focus on resolving that? And how much do we really see that as a core element of our daily leadership task? For me, looking ahead, I think it is one of the most significant things we will have to do. There's some examples. I could quote any, but in the interest of time, I shall merely pick two. Great progress in terms of cutting down the unnecessary cost of temporary staffing. Medical locum spend reduced by nearly £400 million since 2015. Agency spend last year across the NHS driven down by an unprecedented £528 million. Yet at the same time, we know that there's huge variation, and we know that there's more to do. Perhaps more substantively, let's look at clinical services. The data tells us, your data tells us, that, for instance, there's a 300% variation between English hospitals at the length of stay of patients who come in with pneumonia. That sits alongside an assumption that I think we all know to be true, that the NHS is operating its facilities, its hospital facilities, at unsustainably high levels of occupancy. It was extraordinary the way that the NHS responded to the unprecedented pressures of winter, and I am massively celebratory of the work that was done to see more patients over last winter within 4 hours. However, we know that what were described perhaps originally as winter pressures are now continual pressures across the acute sector, and that against the background of rising demand that I've just talked about. So I think we have to be honest and look at things like the variation in length of stay for pneumonia and ask ourselves, why is that the case, and what are we going to collectively and individually do about that? Let me turn then to one potential solution. Nearly 350,000 patients spent more than 3 weeks in an acute hospital last year. And on current trends, that will be a bigger number this year. Long stay patients, those staying over 21 days, account for 8% of admissions in total, but actually occupy 22% of bed days and have an average length of stay of 40 days. And what do we know? Well, we know two things. The first thing we know is that the clinical evidence is that particularly for frail and vulnerable older people, an extensive stay in an acute hospital is ultimately often not in their needs. And nobody wants patients to stay in hospital longer than they need to, but we know that they do. And they do to far greater degree across our system than we would like. I think the other thing we know is that if we are to deal with occupancy levels in our acute hospitals that are running in the mid-high 90s and therefore likely to get in the way of the flow of patients that is so important, we have to do something to free capacity. Short of building dozens of new hospitals, which we are not going to do, we therefore have to focus on things like length of stay and the variances. We have to have the same forensic attention to something that seems very, very difficult, like a 25% reduction in the length of stay of 21-day plus patients to be delivered this year, that we had when we targeted something equally challenging and difficult, the reduction of healthcare-associated infections a decade or two ago. A set of objectives around HCAIs for those of us that were involved that seemed immensely challenging and difficult when we looked at it to start with, but where we made a massive transformation through focus from the top of organisations through clinicians to the front line. The challenge this time, of course, is that the NHS acute sector cannot deliver this on its own. This is a call to action that we are making for the whole of the NHS. The whole of the NHS includes community services, a critical role to play, and also involvement of local authorities. So while the acute sector is massively important in this, this vital objective that will help us care for our patients better is an action call for the whole of the system. The aim being to release up to 8 district general hospitals of capacity as we go into next winter. I know this is a big ask, but actually, having worked in providers, I know this is incredibly important. So this is a major call for us all and a demonstration of what we know we can do with focus and leadership and working across organisations. When you are all under so much operational pressure, I completely understand that it takes real leadership to drive fundamental change in how we deliver care to our patients. As much as I love acute hospitals, and I do, I think we have to be honest and consider whether our models of care have really moved with the times. Let me take a look at outpatients. Or not, if the clicker's not working. Okay, let's not look at outpatients. I was going to share with you a picture that confirms me as an NHS lifer in that only a real NHS lifer would get given a picture of an outpatients department painted by Lowry from 1952 as part of their wedding present. So I do apologise for that. However, I would draw to your attention that this picture from this great city of Ancoats Hospital shows an outpatient in the 4th year of the life of the NHS. Now you can tell that that is not a contemporary picture. I could have a poll and ask how you could tell, but let me give you into the secret. They've got wooden benches from Parks. Now, if I go into an outpatient department, I would see that we had plastic chairs. So in the years subsequent to 1952, clearly we have moved this along. However, outpatients were attended by 64 million people last year, or 64 million outpatient attendances, some of them were more than one, and cost the NHS nearly £8 billion. We've been talking about modernising outpatients for a long time. The challenge for us is to think about whether in the next 5 years we'll be looking at a similar picture. I know this is a big ask. I know this is an ask about a major transformation of care. But the good news, and this is one of the advantages of having worked in the NHS on and off since the mid-1980s, is that I believe that the NHS, the leadership in this room, knows how to do this. Let's just think about mental health. If we want an example of where a fundamental and outstanding transformation of care has taken place, led by the NHS, but with the support of social care, the independent sector, involving patients themselves, let's look at what we've done and what we've achieved for mental health. When I started my career, people lived their lives in huge, remote, distant institutions, separate from society. I know there's a lot more to do in mental health, and I'm the first to say that we need to keep the journey of investment going in mental health. I'm completely supportive of that. But actually, the model of care has been fundamentally altered, fundamentally replaced, and we have supported people with mental illness and learning disabilities to live completely different and better lives. When we look back on the care we used to offer, the model of care looks almost unthinkable now. Yet when we look at outpatients, it looks quite similar. For me, it's this kind of radical thinking and the partnership working that stretches outside individual organisations that we now need to bring to bear on the biggest challenge the NHS will face over the next decade. That is dealing with the care needs of an ageing population. I believe that we need a similar magnitude of change that we've seen in mental health to the way we look after our ageing patients. And that is a huge challenge to the existing care pathway. It's a huge expectation on us all. But I believe that we've demonstrated that we can do it, and we know, I think, that we must do it. So I've talked a lot over the last few minutes about how the NHS needs to become more standardized and less variable, how it needs to become more productive, free capacity, and how it needs to look at its care model. I think it's quite reasonable, therefore, as the Chief Executive of NHS Improvement, for me to turn the spotlight on myself and my organisation and ask, okay, if we're asking the NHS to change and improve in radical ways, what are we doing? How much do we contribute to this? And I believe that NHSI and NHSE as well, to be a solution to these major leadership problems, I believe we have to fundamentally change. We have overseen a £1 billion deficit in NHS providers, while we've seen a £1 billion underspend in commissioning budgets. We've seen that our leadership and support to the front line, particularly in troubled patches, has been fragmented on occasion and, if I'm honest, too often directly contradictory. Those are two examples of why we need to change. And that is why I am so pleased that NHSI has agreed with NHSE that we will fundamentally look to end the fragmentation of our current approaches and replace it with a joined-up working approach. That will include a single approach to the NHS's money at national and regional level, and that will be backed from 2019 onwards from a new financial architecture that will replace that which we've had for the last couple of years, and a new approach to control totals, to sustainability and transformation funding, and to the sometimes punitive rate of interest that we charge our most distressed organisations as they seek to pay their staff and their suppliers. We will also look to have a focus on supporting health economies as much as we look at focusing on health providers and individual organisations like CCGs. And importantly, the third element I would highlight is that we're looking for a pan-NHS approach to improvement and development, covering primary, secondary and community care, rather than the current bifurcation we've got between NHS Improvement's work and that of NHS England's. Backing this is a significant change to how NHS Improvement will operate. Our aim is to shift our emphasis from regulating firmly to being part of the improvement journey. Our emphasis will be on the things that we need to do to help those of you running the services in the front line make the changes that we've been talking about. We'll be focusing on how we can help get the best from the NHS's workforce, how we can build leadership capacity across the NHS, and how we can support leaders, and I will come back to that. We'll be focusing laser-like on the NHS's productivity and its capacity for improvement, and we'll be having a long, hard, and important look at the configuration of clinical services and the organisations that we put around them to make sure that they're fit for purpose going forward. And for me, you will see a set of radical structural changes at national and regional level, with NHSI and E increasingly coming together with single integrated regional teams and national directors, including a medical director, the CNO, and the CFO held in common. But it's a lot more than that. It is a fundamental shift in how we operate. I think it's also, as far as I'm concerned, a fundamental shift in our mindset. We are fundamentally here to do things that will make the sort of challenges and changes that I've been talking about more easy. Let's talk about leadership. Because while the changes we're intending to make, I hope, will be welcomed and, frankly, may be considered to be long overdue, I believe it's obvious that it is the people in this room and your leadership that will either make the success of the next decade and the significant changes we need, or won't. And as I visit hospitals up and down the country, I see great leadership facing often great challenges. I think we also need to recognise that at the centre, we haven't supported our leaders in the front line nearly well enough. I am clear, I'm personally clear, that we at NHSI need to do more to support our leaders in delivering what are undoubtedly some of the toughest leadership jobs anywhere in this country, the jobs leading the NHS. I'm clear that we need to give our leaders time and support to deliver the massive and complex changes that come from turning around our challenged organisations, and I intend to stick with leaders as they go on that journey. I know we cannot expect immediate results from our most intractable problems, and we need to support leaders to create improved trajectories that work over time, and we need to stick with them through that journey. So just to be really clear, we talked a lot about change in the NHS. We talked about the coming together of I&D. My personal commitment here is that I want to underline my intent that we will support NHS leaders taking on difficult jobs as we look to work through the next few important years. So let me conclude. Over the next few weeks, as we look towards July the 5th, I'm sure you will all be celebrating the NHS's 70th birthday in your organisations. I hope you get a chance to celebrate some of the amazing things that you have achieved for the patients of this country. You really need to. But if you're anything like me, your mind will also be thinking about how we get the NHS to be healthy as we look ahead to its 80th. Like you, I wait with huge interest for the long-term funding settlement that the Prime Minister has promised the NHS and that the NHS needs now to receive to rebalance demand with finance. I look forward to that. I think it's very important. The settlement won't, however, change the leadership task ahead of us, the people that run the NHS we love. For me, it's clear that it's us, the people in this room, that will lead the NHS through the next 10 years and make the radical changes that I've been talking about and that you've been talking about at this conference. That is our opportunity and our obligation as leaders of the health service. And as the new Chief Executive of NHS Improvement, I am relishing the task of working with you to turn that into reality. Thank you very much indeed.
Thank you very much indeed, Ian. So again, I'll try and get some roving mics around. If you can put your hands up if you've got questions you'd like to ask Ian. Can I just begin on this? I guess there are two areas within the system where you could derive extra value. One is by doing things better, and the other is by doing better things. The doing things better bit in terms of efficiency within organizations as opposed to the joins, the synapses across the system. How quickly can you get to a point where you're pointing to very large variations across the system? How quickly can we deal with that? With that question, so that we don't, was it a health minister who once said, I am determined that within 2 years all hospitals will be above average, which obviously...
That is not a commitment I'm making today, just...
Good. But so there obviously is this thing about bringing people up and supporting them. A, what's your role in that as opposed to the organisation itself? And B, how quickly, is there some low-hanging fruit here that you think actually could release significant funds in a relatively short period of time?
I think there is a huge amount that can be done. I mean, the reality is we know about the magnitude of variation and we've been bothered about it for a long time. So I don't think it's a controversial thing to call it out. I think the question for me, and it was the same when I was in a provider as it is now when I'm in NHS Improvement, is how do we focus on those things that really make the difference and put our resources down into those and really drive the change? If we do that, I think we can move the dial pretty fast.
And do you think you'll play a significant role in NHSI as identifying, listen guys, you really need to do these things?
So I think the NHSI role is absolutely to, we've got things like the Getting It Right First Time programme, which identifies, you know, what clinical variations exist and how we can look after patients better by addressing that. And I think the work of Tim Briggs and his team is fundamentally important for the NHS. I think we've got things like the model hospital, which demonstrate and document that level of variation. And I think it's our job to champion that and to identify the areas that people could work on. I mean, the reason that I'm particularly focused on the length of stay of long stay patients today is because that is an to next winter. So in some ways, this is about championing Phillips's letter, which is going out today, you will see a reference to the safer bundle, red to green, the other things that we know can really make a difference to patient care and to flow in our hospitals. And we need to see a more consistent application of that. The best hospitals, and I visited one of them, it should remain nameless, very recently, they do this consistently and they get a real flow benefit for their patients. There's still variation. We need to see that addressed. I think our other role, though, is absolutely, as I was saying to Lawrence, to really look hard at capacity and to have an honest discussion with providers about capacity. And that includes, for instance, a long, hard look at seasonality. So typically, we've assumed in 17-18, without getting too boringly technical, a 10% year-on-year increase in electives in January. Well, when I looked, January was pretty cold and there was a lot of flu. Unsurprisingly, that probably was never going to happen. So our conversation about planning is to try and really understand capacity. And we're here to help with some of the support work that we put into that as well.
Okay. Number 3, please.
Hi, Phil Colview, Chief Exec, Cornwall Partnership. Ian, you talked a lot about the example from mental health and how we'd learnt the changes there. We had a lot of political air cover in that when you go back to the Water Tower speeches and a real push for community services. The reality is we need less acute hospitals and more community services, but we don't have any real political cover for that. Whenever you try to reduce acute beds, community hospital beds, you just get people up in arms defending the buildings.
Thanks, Phil. I think I would merely draw on my own sort of personal experience, having been in this game quite a long time. And I think, you know, it's of course the case that change is often perceived as very difficult in the NHS. And it's of course also true that if we're to achieve any of the significant objectives for patients we have over the next 10 years, the development of community services to look after an ageing population is fundamentally an important part of that. I might take slight issue with an assumption that we need a lot less acute beds. I think it's in a rising demand situation we can talk about that, but we certainly need to change the way care is provided, and that means radical change to acute sector. I think for me, you know, we will absolutely back cases that are clinically supportable and logical and well delivered and have been consulted on properly locally. So I don't accept that we can't do this. I think there are examples up and down the country where it has been done and where it is being done. So I don't expect it, if I'm honest, to get any easier, but I believe we can make these changes, and I strongly support the fact that we should make these changes.
Okay, final question from me. How different for a CCG or a trust will their relationship be with the centre in the next couple of years compared with what it's been in the past?
I hope it will be radically different. If I can caricature, and caricature is an exaggeration, so go with it. On occasion, we've perhaps spent more time arguing about, on one side, should we not pay invoices, and on the other, should we just bill even more? And that is not a model for success over the next 5 years. Arguing about who owns the deficit in a patch is obviously kind of important, but fundamentally, if we look at the next 5 years of the NHS, I don't think that's going to turn the dial. The aim here is to look at the patch as an entity and to bring the financial models together. I hope, therefore, that if we look back in a couple of years, we'll see NHSI and NHSE having created a system of a single approach to money. We'll have, for instance, less. To give one tangible example, the one trust that I know about that had thousands and thousands of contract variations sent in 1 month. And that is a pointless activity. So there's an opportunity to bring the money together, to look at patches, to support the work of integrated care systems. That, I think, will be a fundamental change than looking back to a payment by results, turn the turn style type of approach to money. So I think it will be profound. I think it'll take a while to get there, but that is our objective.
Okay. Ian Dalton, thank you very much indeed.
Thank you, Neil.
Thank you. Very helpful. Okay, I'm going to release you rather late for coffee. Apologies for that. And then there are workshops starting from 12 o'clock. Thanks very much. Thanks. That was very good.